FFP and Cryoprecipitate in the UK, which is the topic of conversation. So over to you, Dr. New. Thank you very much.
Thank you very much, and it's very nice to follow those other two great talks. This is by way of a fairly brief update, and I'm also got a few slides from Al Hunter, who is the frozen component manager for NHS Blood and Transplant, who can't be here today. So I'm essentially just going to cover a bit about the history of the changes that we're going through for paediatric FFP and cryo, and to just go over the implications of those changes. And I've got a few final slides from Al talking a bit about the logistics, which we're all going through, and no doubt you're feeling from the hospital end as well. So for the history, as no doubt many of you will remember, in 2002, there was a decision made to provide pathogen-reduced UK FFP for infants and children born after 1995. And in fact, in July of that year, it became available. And this was all part of preparing for the decision that was imminently made to import pathogen-reduced FFP to reduce the variant CJD risk. And that was part of the ongoing changes that were all being put into place at that time over the concerns about transfusion transmission of CJD. So by 2004, non-UK single donor methylene blue FFP was being imported for children less than 16 years of age. It was methylene blue treated because of the higher incidence of viral markers in source countries. The initial source country was the US, and then later on it became Austria and then Poland, but overall they all had a slightly higher background rate of viral markers. So the methylene blue FFP, the methylene blue treatment, was brought in for that reason, for no other. And as many of you will know, pathogen inactivation, most types of pathogen inactivation do have some impact on the coagulation factors, and methylene blue in particular reduces factor VIII and fibrinogen by about 20 to 30%. In 2009, the introduction of FFP, methylene blue treated FFP importation was followed by Cryoprecipitate, again for children less than 16 years. And as the years rolled on, those born after 1995 were becoming greater than 16 years of age. So because that 1995 cutoff was the one in which VCJD was felt to have been removed from the food chain, from BSE, from the food chain, the decision was taken that it was logical to, once those children became, once those recipients were more than 16 years of age, we should continue providing methylene blue FFP and cryo. So for all of those born after 1995, in 2012, that decision was made, and that's where we've been until recently. And last September, the DHSC reversed the guidance following a review of the risks and whether it was still the right thing to be doing, to be importing all this plasma. And the guidance then was to cease importation of plasma as the VCJD risk reduction measure. And everything else flows from that. And I've given you the link to the announcement at that stage. The decision from the DHSC followed on from recommendations that were made in a report earlier in 2019 that had been drawn up by the Paediatric Components Working Group of SABTO, which had been pulled together in 2017. And its remit was to advise whether the risk reduction measures for transfusion and transmission of CJD for patients born after 1995 should continue. And those were, as I've said, the importation of plasma, which was also for patients with TTP. But in addition, it was recommended that apheresis platelets should, where possible, be used for those recipients because there was reduced donor exposure as a result, and therefore, again, a theoretical reduction in the risk of VCJD transfusion transmission. And the committee reviewed numerous factors in making the recommendation, and the primary one was, of course, a comprehensive updated assessment of the VCJD risk.
Awful.
Because that was...
I was thinking, oh my God, I'm thinking, it was awful.
Oh, somebody's not, yeah, need to then mute on, I think.
Helen Cook, Dr. Cook, we may have you on mute. Sorry, Dr. New.
It's fine. I was wondering if it was my end. So the main thing was the comprehensive updated assessment of the VCJ risk, because as you'll know, we saw far fewer cases coming through than had been predicted, but also whether the current measures are sort of actually reducing the risk for one part of the population but not another were equitable. Accepting that there was operational difficulty in keeping these separate lines of plasma, and also a major aspect around cost effectiveness. And the assessment of the risk was very much that it was lower than had been previously forecast, and in fact stopping plasma importation was estimated to possibly result in just one more additional VCJ death in approximately 45 years. So really, although it's an increased risk, it was actually a very tiny risk in the balance of all the other risks that we take, and certainly when it's looked in the context of the operational cost and all the other aspects, the recommendation was made to reduce, to withdraw this risk reduction, well, both the risk reduction measures. So where are we left after the SABTO and DHSC recommendation regarding any special plasma and platelet components for the paediatric age group provided by the UK Blood Services? Well, for plasma, that is now the handover is occurring, but that will be all UK for FFP and cryo. And in fact, the only different provision is that it from standard FFP is for the neonatal and infant specification for neonates and infants under 1 year of age in small volume packs, and I'll go over that a bit more in a moment. And there is no longer recommended to be anything different for any recipient from 1 year of age onwards, and no longer recommended, of course, that we should have imported or pathogen inactivated plasma for these recipients born after 1995. And for platelets, again, the only age group that gets anything different for platelets are those under 1 year of age, where they have a neonatal and infant specification. And these are apheresis packs, they're small volume packs, and they have 20% platelet additive solution. And that addition of the additive solution was rolled out earlier this year. So there's no longer the recommendation of apheresis for older recipients born after 1995. What are, if any, the implications of this change, essentially a change back to using UK plasma for the paediatric age group? There is a different specification. This provision of neonatal infant specification wasn't there for the methylene blue, which I will show you in a table in a moment. There will be a difference in the coagulation factor content, particularly for the factor 8, which will be higher. The pack volumes I will show you are pretty similar, and there is a distinction in the shelf life, which again I will show in a moment. What about efficacy? Should we be concerned in any way about changing to UK plasma? Well, this seems highly unlikely, and if anything, things should be better. As I said, the methylene blue did reduce the factor 8 and fibrinogen, although there was never felt to be a significant implication clinically as a result. And I will show you a slide again reassuring that there should be no implications from the safety angle in a moment. But I do want to note, of course, that what I've been talking about is all the UK Blood Services provision of plasma, the single donor plasma that's provided, and solvent detergent treated pooled FFP, Octoplas LG continues to be commercially available in 200 ml units as before for those hospitals that use it. Just a quick word, I keep using this term fetal neonatal infant specification. In fact, in the JPAC guidelines for the blood transfusion services, it's a sort of fetal neonatal infant specification because it has a number of common features, and blood components of this specification are suitable for recipients of up to under a year of age, essentially, and they're designed to have particular additional safety features for this vulnerable age group. And it's the fact that it's all up to a year of age is sort of pragmatic in pulling together things like CMV negativity, second time donor, there are various recommendations around various of these aspects, and the actual age cutoff is slightly different, but there's a pragmatic component that is available with all these features for recipients under a year of age, and the details are given in the JPAC guidelines, and the website is there, and they have been, it's also described in the BSH Paediatric Transfusion Guidelines, with a recommendation that recipients under a year of age should be transfused with these components. Although, of course, and this follows on from Fatz's talk as well, in a major hemorrhage or emergency situation, of course, blood provision should not be delayed in order to fulfill these special requirements, and there should be pre-agreed hierarchies of alternative components and communication pathways in that situation. So what is the neonatal infant spec for plasma? Really the features are generic across all components, and red cells and platelets have additional features, and they are firstly for infection risk reduction, that the donors should be so-called second-time donors who've given blood at least one time in the previous 2 years, which is negative for the mandatory microbiological markers. And there's also a specification relating to hemolysis risk reduction. So there's a so-called paediatric antibody test looking at atypical antibodies, and in particular they are high titer. They are all high titer anti-A and anti-B negative. The non-UK methylene blue plasma didn't have these features. It wasn't from second-time donors, but of course, because it was pathogen reduced, pathogen activated, this compensated, and therefore that wasn't an issue. It wasn't high titer negative, and that meant that there wasn't the option if your first choice group compatible was not available, that you could use a high titer negative alternative, and therefore really the recommendation was to only use non-group compatible in an absolute emergency. So having high titer neg actually takes us in this situation closer to the availability for standard plasma, or at least all of the neonatal infant is high titer neg, whereas standard plasma you can get it. So this is just a table giving you a basic comparison of the non-UK methylene blue components, which have been used to for so many years, versus the UK plasma components for the paediatric age group. So on the left is the non-UK plasma, on the right is the UK plasma. So regarding the neonatal infant specification, as I've said, there was no such thing. So for the UK methylene blue, non-UK methylene blue, it was all the same, whether you were a neonate or infant or an older child. For the UK plasma, yes, there will be and is already a neonatal infant small volume FFP, and cryo singles will be the neonatal infant specification. For children from the age of a year and above, then standard large volume FFP or cryopools would be not from the neonatal infant specification, although of course it still may be appropriate to use multiple small numbers of cryo singles for a small young child. The volumes, oops, sorry. Can we go back? So for the volumes, the volumes for the small volume FFP, it's pretty similar from the new non-UK methylene blue and the new UK one, and so similarly with the large volume. I think the main difference will be that the cryo pools for non-UK methylene blue actually had 6 donors contributing, whereas so they were actually a larger volume than the standard cryo pool. So that was in order to fulfill the fibrinogen specification for a pool. So that is just something to consider, and therefore the concentration of fibrinogen will probably be higher in the standard FFP now than it was in the non-UK methylene blue pools. The shelf life, the neonatal infant small volume UK plasma will have a 24-hour shelf life, as distinct from the standard large volume UK plasma, which is usually 24 but can be 120 hours for unexpected major hemorrhage. And of course, that's a situation where if you had a small child who came in needing plasma urgently, that if necessary, they would need to, and there was pre-thawed FFP from a standard adult pack, then that would be a situation where you might well use concessionary release because of the clinical need in that situation. The FFP factor 8 specification for the non-UK methylene blue was lower, as you can see, compared to the UK plasma, and the cryoprecipitate fibrinogen specification is the same in both situations, although, as I said, the concentration in the standard pools of UK plasma will be higher than it was in the methylene blue pools. So that just gives you an overview of the differences. This slide goes back to the reaction rates. I mentioned any likely differences in reactions from UK versus using the methylene blue, and this is a slide that where we looked a few years ago at reaction rates comparing from shot data reaction rates between methylene blue and standard FFP and also solvent detergent, and essentially we looked at all the types of acute transfusion reactions against the with the rate of reactions reported, and you can see that in the bottom line is the statistical comparisons, the FFP versus methylene blue, either for all acute transfusion reactions, for the non-severe or for the anaphylactic severe allergic reactions was identical. Well, there was no significant difference. The only difference was in the very small number of severe hypotensive reactions, but this was felt unlikely to be clinically significant as they were all particular types of patients and the numbers were so tiny. So at that time, the data was considered to support the continued use of methylene blue FFP in the UK, and I think again it is supportive and reassuring that there would probably be no implications for the current switch to UK from non-UK methylene blue treated in terms of reaction rates. And the next slide simply shows a histogram, and you can see that the methylene blue is in grey and the standard FFP is in light green. And actually there were very, very wide confidence intervals because of the small numbers of cases, and it was actually only those severe hypotensive ones that really showed a difference. Finally, just to mention, it was discussed as to whether the whether the UK FFP for the paediatric group should be actually pathogen activated, because of course all these years they have been receiving pathogen activated plasma, although of course before that they weren't, before importation. And so a viral risk and assessment was undertaken just to consider this, whether there is any risks that one ought to be looking at and considering pathogen activating. The highest risk, looking at the epidemiology in general for transfusion, is of hepatitis B, but the overall risks in fact are lower than prior to the plasma invitation phase, and for example NAT testing has been introduced since then. And the figures and the assessment was reviewed by JPAC and the Standing Advisory Committee for Transfusion Transmitted Infections in October last year, and the risk is very low, and overall there were no significant concerns with the use of non-pathogen activated treated UK plasma for any age group. So the decision was made that this was not required for when importation was ceased, and the minutes from the JPAC meeting are available if anyone's interested. And all of these details are covered in an addendum to the pediatric guidelines, and that is available on the BSH website, and it's in press in the British Journal of Haematology. And there's also a parallel addendum to the BSH FFP guidelines, which essentially has got identical information in it regarding this aspect. And finally, just a few slides from Alistair Hunter, just describing a few of the practicalities of the changeover, because before the decision was taken to stop importation, there were two plasma supply chains, the methylene blue imported and the standard plasma for all other patients. And because there was quite a big difference in the cost of the importation, the two were priced differently. However, following the decision to change over to UK plasma, and we could go to the next slide, NHSBT convened a project to convert to domestic plasma self-sufficiency, and as you'll know, initially they stopped issuing the large volume methylene blue packs, and instead hospitals are using standard plasma for the patients from a year and above, and then the neonatal infant specification small volume components from UK plasma were planned to be rolled out from this year, in August 2020. And in order to reduce wastage and cost, NHSBT merged these two work streams, so the UK and the non-UK components, into a single plasma inventory, and so they could be issued interchangeably, and it was agreed that they should be charged the same price irrespective of the plasma's country of origin. So how is that going in terms of timing? Well, it was originally pre-COVID planning assumptions assuming normal demand patterns and exhaustion of they assumed that there would be exhaustion of the non-UK plasma by about August, September 2020. But in fact, because of demand suppression due to COVID, there's still a lot of supplies of the small volume methylene blue plasma components. So they will still continue to be issued until about early 2021. Finally, as Alp said, NHSBT has factored in a potential gradual increase in overall FFP demand as some hospitals consider their plasma options and alternatives. And to support planning, we'd obviously welcome as much advance notice as possible if there are likely to be policy changes affecting the demand for FFP. And finally, I've got just finally a plug for something else paediatric. This is completely unrelated to plasma. I just got one last slide. And that is, for those of you who aren't aware, SHOT has launched a paediatric educational video this summer on haemovigilance in neonates and children, and they've put a lot of resource into their educational videos, and it has got some lovely animations in it, so I would commend it to you if anyone's interested.